And just very briefly, in North Dakota, for the North Dakota Telepharmacy Project, you'll find basically the same equipment in a retail telepharmacy as you will in a hospital. It's a standard PC, that video conferencing element. It needs to be privacy protected and HIPAA compliant, so there's the virtual private network. The document imaging camera, we'll be seeing a few slides with all of these things pictured, but that's the piece of equipment that focuses down on whatever the tech or nurse is working with, so that the pharmacist can view it again in real time. And then there's the added component of the pharmacy operations software along with the video, audio video link, and they run in parallel rather than to be integrated, I guess would be the right word, because then if for some reason the visual link does go down, the prescriptions could still be dispensed by use of more conventional means, so such as the phone or fax. So that's basically it. And as we sometimes say, it's very effective. It's safe. It's cost effective, and it's also not rocket science. And this is the cost of one setup, either the central site or the retail site, and it comes to just over $17,000. There we'll be seeing here shortly a couple slides that show a cart that's been developed exclusively for, I guess, use in hospitals for telepharmacy, and that's an additional $5,000 per site. So again, it works extremely well, and it's also well scaled for the type of institutions that are in North Dakota and that we work with. There are large and costly automated dispensing machines, which for the size of hospital or retail operation we're talking about, for the most part, they are unnecessary and at much greater expense, when this does extremely well. So in terms of the transmission between the central and remote sites, in the retail setting, it's all done through the first bullet point there, over VPN DSL line provided through a local internet service provider with a minimum of 512K bandwidth, and it is a point-to-point system. That all of the retail, again, that's the majority of the sites, receive their transmission that way. And then in the hospitals, actually use all three. Some of the small hospitals, especially when there's a small group of hospitals that can provide services to back each other up. They do use their local internet provider. And then, but the hospitals have two other possibilities, and one is that they can go across, transmissions can cross the BT1 system, or, and I'll explain just very briefly toward the end, we do have a hospital system that's involved now with hospital telepharmacy, and they have their own wide area network that transmissions can go through that way as well. So Kim asked me to talk about any improvements that would help our current system and increase its reliability. And I would say the major things that we've run into are fluctuations in bandwidth during times of heavy internet use, and that does cause some reduction in visual quality. But we have across the board, even in the last 9 years, almost 10 years that we've been operating, the equipment actually has improved significantly, including the definition that you can get with one of the digital imaging cameras. And so it's not, if the reduction were enough to be a safety issue for patients, we wouldn't be doing this, but that's not the case. But still, it's an improvement that could be made. And then, of course, any of the hospitals using the BT1 for their transmission, in the case of a bioterrorism emergency, they would be basically kicked off the network and have to find other means. So I'm just going to go through a few slides so that you have a chance to see how the technology, the process look, and a few of the people behind that process. This is what you're seeing here is a technician who is in Enderlin, North Dakota. And the pharmacist you see on the screen there is Walt Spies, and he's located in Lemoore. And he is, together they are processing a prescription for someone. And again, he is in charge here, and she is assisting him. Lemoore, I believe, is about 70 miles away from Enderlin, and Enderlin had been without pharmacy services for 16 years when Walt obtained the old Rexall drugstore. It still has a great sign out front that says Rexall drugstore, but so they were extremely pleased when Walt developed this business for them. Okay. And this is what the pharmacist sees in the retail setting. In the hospital setting, it's slightly different because instead of a prescription here, we would be seeing a medication order. But there's the prescription, the label, the drug, the container, and then again the high definition camera can also focus in and even ID the ID code that's on an individual pill. And in the hospital setting, this is the sort of original traditional sort of setting where the hardware and I guess accompanying software is located on a counter in a hospital pharmacy. This happens to be in the Rugby Hospital. And there are several hospital models, and I mentioned one of them. The second one down is where several rural hospitals back each other up. The other one is where a local community pharmacist serves as a consulting pharmacist for a rural hospital. The majority of small town hospitals are run that way. Are served by pharmacy that way. And I'm going to kind of skip down here to, again, there's the mobile cart, and then there's a new thing which we've helped establish just in the last 2 years, and that's a central pharmacy services hub site here in Fargo, which can serve multiple rural hospitals at one time that contract with them. And this is what it looks like in the hospital. This is actually the first prototype of the cart. The more advanced one you'll see in a moment here, but it can be moved anywhere around in the hospital where the pharmacy services might be needed. And the tech here in this case, the reason we can see the medication up on the screen there is because the document imaging camera is focusing down on it, as you see in the left, a little bit better. And we are seeing exactly what the pharmacist is seeing at the other end of the process. And in this case, that same mobile cart has been moved out into the nursing area, and where the cart can be used so that nurses, technicians, and even physicians can get consultation from a pharmacist that's at a distance. And it can also be brought to the bedside so that the pharmacist can meet face-to-face with patients. And in this case, this is a shot of, again, the hub site that I mentioned to you that's here in Fargo. They are currently providing 24/7 pharmacist staffing to rural hospitals. Again, what we're seeing here is on the screen is either a tech or a nurse that's at the other end, and that's preparing something for the pharmacist to assist with. And they, as clinical pharmacists, I just want to say they actually provide a wide range of pharmacy services for hospitals. But the major thing, as we all know, in a lot of small hospitals for many years, really the only way they had for medications to be brought to a patient was if a nurse did it. But this provides the hospitals with an added an important layer of staffing with increased service and safety. So this quote up in the corner, that a pharmacist's oversight via telepharmacy has potential to improve quality and reduce errors. That certainly is the case, and we here in North Dakota, we know it doesn't just have the potential that it does. And that's because of findings of a medication error study that we conducted over a 45-month period for the retail pharmacy setting. And it shows that North Dakota telepharmacy error rates are less than 1% per year. And the national average of error rates is 2%. So we're very pleased with the positive results of that study. And are conducting a similar study in terms of error rates in the hospital telepharmacy setting. And we're actually publishing an article, I think it's coming out in July, about this study. And any additional research, it's very, very important, as Russ mentioned in his previous talk, that not only to publish results such as this so that telepharmacy grows as an addition to the healthcare possibilities for small communities, but also getting it out through the means that have been talked about today, so that communities, states, individual pharmacists, community pharmacists, we do quite a bit of consulting with those folks who they hear about our project and want to duplicate it, and getting that research out there is really the best way to do that. So we're pleased that again what's being spoken about today can help spread the word, not only about what telepharmacy can offer, but many things like this. And just lastly, again, I think that cyber infrastructure will help telepharmacy reach that potential, and we look forward to being a part of that.
Thank you, Ann.
We did have a question come in on the chat, if I can quickly ask, and I think actually the first one you already answered, explaining step-by-step how telepharmacy works in various settings. The second question is, though, how many remote sites do individual pharmacists deal with?
Oh, okay. As part of the Board of Pharmacy rules, they allow for 4 remote sites, but no more than that.
And how efficient